Reversible pierce, you cannot reverse the cells of the bone in the places which can, but in order just to stop the fracture, that's all.
Alright, well, Dr. Nizar Abu Faraj, thank you very much for joining us on the program and shedding light on osteoporosis.
Thank you very much.
Thank you.
Thank you very much.
And that was our guest, Dr. Nizar Abu Faraj, an orthopedic consultant, kindly taking the time to sit with us and talk to us about osteoporosis awareness. We are now going to go on a report about osteoporosis, and we'll be right back to introduce Dr. Khalid Al-Namiri, consultant and professor of cardiology interventions and nuclear imaging, talking to us about arterial catheters. Stay tuned.
Osteoporosis, or brittle bones, is an age-related disease that often leads to fractures of the hip, wrist, and spine, affecting millions of people worldwide. In this vertebra, we see normal, healthy, cancellous bone. In time, however, osteoporosis results in resorption and reduction in the amount of cancellous bone. The weakened bone is unable to withstand physiologic loading and eventually fractures. Vertebral compression fractures can cause debilitating pain in the neck and back. Sometimes this pain is confused with muscle strain. Vertebral compression fractures can also lead to deformity, as shown here. Fractures may also reduce mobility and deteriorate one's quality of life.
Welcome everyone. And the last report was still talking about osteoporosis, brittle bones. Now we're moving on to our second topic this evening, which is about arterial catheters. And with us we have Dr. Khalid Al-Namiri, a consultant and professor of cardiology interventions and nuclear imaging. Welcome, Dr. Khalid.
Thank you. Thank you for having me.
You're most welcome. So, Dr. Khalid, if you could first give us an idea about what is a catheter and what is an arterial catheter.
Okay, so a catheter is a little tube where you can insert it inside an artery, and you can push a dye and can take pictures for that artery. And while we are doing it, we want to know if the artery is blocked or not. And number two, and if it's blocked, can we open it or not? So basically, this is a very simplified method of understanding it.
And is it very easy procedure to do, to put in a catheter?
It is. Cardiac cath procedure or arterial catheters, it's a day surgery procedure all over the world, i.e. it's a procedure where you come to the hospital, they do a freezing in your skin. It could be done from several ways. It can be started from the radial artery, it's an artery around the hand, where you can do the catheter. The catheter procedure, inserting the catheter inside the heart and taking pictures from the heart and coming out just to see what's going on. It doesn't take more than 10 minutes. Okay, so it's a simple procedure. After doing the procedure from the radial artery, they put a gauze on it and strap it. You can mobilize and you can go home after 4 hours. If you have, there is another way in the upper thigh where they freeze the skin, and this is the traditional way of doing catheters. Then they have not to mobilize their leg for 4 to 6 hours. Then after that they can go home. I.e. just diagnostic procedures, they can go within 4 to 6 hours home. Now, if it's intervention, you're gonna open an artery. No, at that time you have to keep them overnight. I.e. next day they can go home.
So now this is basically just to investigate. I mean, the tube is just goes into a blood vessel.
That's right.
And then you just push in the dye, and then you do like an MRI or a CT scan, or is it different?
Okay. What's happening? The dye has to be an iodine dye.
Yeah.
Iodine. It's so you put the catheter inside the artery and you push the dye. The dye, because it contains iodine atoms, and you do an X-ray, just like the X-ray. It's absolutely it's an X-ray.
Oh, okay.
So the X-ray from the tube is behind the patient, under the table, and the receiver on the top of the patient, and the dye in between, the heart and the dye.
Yeah.
So you reflect the shadow of the contrast on the X-ray, and it shows in front of your screen. So this is the beauty. It's a life method. The first catheter was in 1970s, in 1965 to 70. So, and after that has been improved, the method of doing the catheters. Catheter procedure is not a difficult procedure, but it has a risk. And any patient should go for this procedure, should understand that risk. 1 in 100,000 to have a complication. Complications could be a small heart attack, or stroke, or death. It's it's a risk. You can have 1 in a million risk of having an accident and dying in the highway. Okay,
sure.
But it's the right of the patient to know that risk. Whether he will accept it or not, this is his right. That's why the consent is a major part of doing the procedure. There is people, when you tell them that ratio, they will say, you know what, I don't want to do it. And this is his right, as long as he understands the benefit and risk of doing the procedure.
It's 1 in 100,000, right?
Yes, this is in just having diagnosis and coming out.
But I'm sure, like, the person with the mini heart attack and the mini heart attack and death, those are the only two that really registered. You mentioned 2 other complications, but I don't remember them. You said mini heart attack and what else?
Okay,
mini heart attack.
It's 3 major things.
3 major.
Either heart attack, or stroke.
Stroke,
or death.
These are basically based on the fact that the person will have, we can say, because you're injecting something into his blood.
That's right. Into his coronaries.
The contrast.
That's right.
Now, when you said that it started in the 70s and to this day it's been improved, has it improved in lessening the toxicity of the contrast, or in making it easier, or
in all these aspects?
Okay.
In the type of the contrast, in the usual contrast before, they were having fibrillations because it contained high iodine atoms and high weight. Now the contrast is less weight, so it doesn't fibrillate the heart.
Okay.
And the injection particles becomes faster and smaller. And the technique, the catheter where you inject is less. It used to be with push catheters. So it has improved a lot recently. But the numbers I'm mentioning, this is all over the world, like from China to Los Angeles. These are the numbers. Now, if you're gonna go inside the artery and put a stent or remove a clot, then your risk goes to 1 in 100. Okay, 1 in 100. But still, his benefit outweighs the risk. If you have somebody who comes in the accident in emergency room with heart attack or severe chest pain, if you leave him alone with medical therapy, his risk of dying 10%. 10%.
Yeah.
Okay. If you take him to the cath, he will have a risk of 1 in 100.
Sure.
So it outweighs the risk completely.
Of course. As medical providers, you know that you only present something that has more benefits than.
Absolutely.
Okay, now let's go to something else, which is an angioplasty. What is an angioplasty exactly? Is it different from? How does it differ from?
Okay, an angioplasty is the same exactly as the catheter, where you go inside the artery, go inside the coronary artery, inject a dye, and then after that you use the tube to carry a vehicle, where you can carry a balloon inside the artery, where you open the artery. The cholesterol inside the artery, which you block, it's blocked, you open it with the balloon. Then after that you put the stent. So you are reconstructing the artery.
So the angioplasty is the intervention, not the diagnostic method.
Absolutely.
So angioplasty comes after the catheter when you realize that there is a clogging and you need to remove it.
That's right.
And now, is the contrast the same in all imaging diagnostic methods? Like
we use.
If you're doing an MRI for
no,
MRI is different.
Okay, the contrast for the CT, because the CT also is an X-ray.
Yeah.
Okay. So, but has a high turnover, fast turn device, imaging devices. But the contrast used in the diagnostic is around 70 ml. So it's very small amount.
Yeah.
But when you do intervention, because you are taking a lot of images, it can go up to 250 to 300 ml. Okay? Now, if you're doing a CT picture for the heart, you will take approximately from 70 to 90 ml of dye with the contrast. Now, the contrast of the MRI is completely different. It's called gadolinium. It's completely a different contrast. It doesn't use the contrast of the X-rays.
It's safer, or?
Well, it has its own problems.
Really?
Yes.
Because I took an MRI about a month ago, a brain MRI, and they didn't tell me about any risk factors at all.
Well, it depends with the gadolinium or without gadolinium and with the contrast you use for the brain. I'm talking about the heart imaging. But in any procedure, it is the right of the patient to know the exact details. Even if it's minor, he has to know about it.
Of course, of course. Well, right now we're going to go on a short report on arterial catheters, and we'll be right back with Dr. Khalid and Nimr. Stay tuned.
I'm Vic Martoro and I'm a CVS pharmacist. If you've just been diagnosed with osteoporosis, there are fortunately several lifestyle changes and medicines that can help prevent further bone loss. Make sure you are at a healthy weight. Follow a diet that is rich in calcium and vitamin D. Try to get at least 10 to 15 minutes of direct early morning or late afternoon sunshine on your face and arms. Exercise regularly, especially walking, running, stair climbing, or dancing. Don't smoke. Cut down on caffeine and drink alcohol only in moderation. All of these changes can aid in the prevention of bone loss. Aside from making these lifestyle changes, a doctor may recommend a prescription medicine as well. Drugs that treat osteoporosis include bisphosphonates, calcitonin, raloxifene, and parathyroid hormone. You should talk to your doctor first and find out which methods would be best for preventing further bone loss. And remember, you can always stop by and talk to your CVS pharmacist. We're happy to help.
Welcome back. And now we're still continuing talking about arterial catheters, as the last report was discussing. Now with Dr. Khalid Al-Nima. Welcome back, Dr. Khalid.
Thank you.
And Doctor, first of all, how does the cardiologist, based on what does the cardiologist decide which method, whether he uses an arterial catheter or a normal catheter or the angioplasty, how does he decide to use this on a particular patient, and what makes him decide this?
Okay, there is indications in the literature, and there is standards of performance, and this is very strict criteria. I.e., if you want to evaluate a hospital, then you should go, instead of going, okay, I'm going to see how many appendix surgery they did, you should know the parameters of performance of arterial catheters, because it does indicate a lot of information, i.e., patients with heart attack, when you come to the emergency room, when they did the ECG, if the average for 100 patients, 200 patients, they should do it within 10 minutes. If the average of performance of the ECG for a heart attack is 30 minutes, it means that hospital is lagging behind a lot. They should do something on the performance. If the time from the coming through the door of the emergency room until doing the catheter is more than 90 minutes, then this hospital has an issue about performance. Then there should be correlation between the ER, the emergency room, the internal medicine, cardiology, staff of the cath lab. They should be pushed to do better performance. Who should go for cardiac cath? There is certain indication, but we'll mention the major ones. The major one, somebody who has a fresh heart attack, i.e. he presented to the emergency room within 6 hours, and he has chest pain, and he has no contraindication to having a catheters. There are some people who comes with a heart attack, and they are within the window, but they have bleeding problems. They have severe allergy to contrast. We cannot use iodine. There is people who come with, they don't want catheters, as simple as that. Okay, they want to treat it medically. So there's people who have bleeding tendency, i.e. brain problems, brain hematoma, brain clots. Because when you go through catheters, you should have blood dissolving agents like heparin and antiplatelets. So those people you can harm them. So in case there is no contraindication, you should take them to the cath lab, do the angiogram, see where the clots, take it out. Why? Because if the mortality, having the death within the hospital with a fresh heart attack is 10%. If you leave him alone, so you better take him to the cath lab and take the clot out. But if it's somebody who presented late, i.e. more than 24 hours, he has done the deed, already infarcted his heart, you're not going to gain much by taking him to the cath lab. So you expose him to the risk and you don't have benefit. So those people you should not take them to the cath lab. Another people who have diabetes, high blood pressure, and they presented with chest pain, and you do a stress test for them, and they have chest pain and they have ECG changes, i.e. they could be having clogged arteries, they could have cholesterol blocking their arteries. Those people, you should take them to the cath, to the coronary angiography, to see where is the blockages and how many arteries are blocked, and you discuss it with them. Some people who presented first time, they have no risk factor, and they presented with heart failure, weakness of the heart. Those people, they should go for cath, because the major killer all over the world is coronary artery disease. So we have to be very aggressive in their diagnosis and in management, because it makes a difference in life people.
Sure, yeah.
So those are the major three categories for diagnosing coronary artery disease using cath.
Well, Dr. Khalid, now after this procedure is done, whether, excuse me, however the method was done, whether it was diagnostic or the intervention,
yes,
what is the usual, the things that patients should not do, or the things that patients should do after this procedure to have a quicker and safer recovery from the procedure? What are the mistakes that they should avoid?
Okay, there's a few mistakes. Number one, let's talk about the traditional way of doing catheterization and angioplasty. Somebody who came with a heart attack, you freeze the upper part of his thigh, you went through the femoral artery, you took the clot out, then after that you told them the patient should not move for 6 hours. Then suddenly the patient move after 2 hours. He want to go to the washroom. Why he should not move? Because he could bleed and a hematoma can form, i.e. blood accumulation. He should not move, and the nurse should watch him for 6 hours, and she should push so that the blood does not collect around the puncture site. This is number one. Number two, after 6 hours he can mobilize, but you watch him. Of course, long time ago we were asking people not to be mobilized after heart attack, but now after 8 hours we ask him to be mobilized, and we ask him to be moved in the ward. Next day, if he's stable, he goes home, but he should not carry heavy lifting, he should not carry heavy weight, he should not drive his car for at least a week. He should, after 1 week, come to his physician. He should enjoy his life, avoid his fatty meals, and take his medication regularly. These are the regular advices we give them.
Well, Dr. Khalid Al-Nima, consultant and professor of cardiology interventions and nuclear imaging, we'd like to thank you very much for being our guest this evening and informing us of very, very important, actually, information that you've just shared with us. Thank you very much.
Thank you, and thanks for the audience.
Thank you very much for being with us. And now we're going to go for a short report, after which we'll be stay tuned.